اوكي. المحاضرة هتبقى على guidelines of monitoring ovarian response during IVF ICSI cycles. هو الموضوع كله عبارة عن just only 4 questions regarding the guidelines for monitoring of ovarian stimulation. طبعا برضو النقطة اللي احنا هنتكلم فيها these are the 4 questions regarding the monitor أو guidelines for monitoring. الحاجات دي ما هياش ثوابت علمية، يعني ممكن الكلام ده يبقى فيه نوع من الارجيومنت، ممكن يكون فيه نوع من انا ما بعملش كده، طب ممكن احنا نتفاهم مع بعض الامور ممكن هي تمشي ازاي. يعني ده ما هياش حاجة ثابتة. يعني لو انا ماشي على بروتوكول معين وانت ماشي على بروتوكول كويس وبتعمل مونيتور كويس ويل اند جود، لو انت عاوز تعمل اي تعديلات او اي حاجه جاست ثينك في الاربع نقط دول او 4 اسئله دول. كلنا بنعرف نعمل السونار، كلنا بنشوف الحالات، كلنا بنتابع الجروث اوف ذا فوليكلز، كلنا عارفين نختار الدوز فور ستيميوليشن، انيشال دوز اوف ستيميوليشن. كلنا بنعمل مونيتور. المفروض ان احنا نقلل عدد المرات بالنسبه monitoring of the patient. انا شخصيا كنت بعمل اول مونيتور بعد 5 ايام من الاستيميوليشن، وبعدين بقت 6 ايام. دلوقتي اكشولي انا بعمل اول مونيتور 8 days of stimulation. طبعا برضه دي حاجه كونتروفيرشال على حسب الاكسبيرينس على كل واحد. النقطه الاولانيه اللي احنا بنتكلم عليها في اللي هي جايد لاينز is the addition of hormonal assessment اللي هو Estradiol, progesterone and LH to ultrasound monitor affect the efficacy and the safety of ovarian stimulation. ده اللي احنا عاوزين نعرف. الحاجه الثانيه does monitoring of endometrial thickness affects the efficacy and the safety. Monitoring of the endometrial thickness هنا المقصود به on the day of embryo transfer، لكن الديفولت بتاعنا اللي احنا بنقيس الاندوميتريوم throughout the stimulation cycle till the day of HCG. السؤال الثالث is the outcome of ovarian stimulation depends on the criteria of triggering. يعني انا هعمل التريجرنج بتاعي on what base. ايه هي الكرايتيريا اللي انا هقول خلاص انا خلصت العلاج بتاعي وهبتدي اعمل التريجرنج of ovulation. Which criteria for cycle cancellation are meaningful for predicting poor responders and high responders؟ امتى افكر ان انا اعمل cancellation for the cycle؟ في الاثنين extremes of ovarian response. امتى افكر في الكانسليشن لو انا عندي poor responder، وامتى افكر في الكانسليشن لو انا عندي high responder؟ هناخد اول حاجه اللي هو اول سؤال اللي هو is the addition of hormonal assessment to ultrasound monitor. يعني هل احنا يكفينا ان انا اعمل مونيتور just pure ultrasound monitor علشان اقدر ان انا اوصل safely و effectively للستيميوليشن بتاعي والاند اوف ستيميوليشن والتريجرنج اوف اوفيليشن، ولا الاديشن اوف هرمونال اسسمنت زي الاسترادايل E2 progesterone and H are important؟
Emad, can I excuse you to speak in English pure, because some foreigners are with us in the webinar. They are asking.
Okay.
Thank you.
Okay. So our first question is that should we add hormonal assessment as estradiol, progesterone, and LH to ultrasound monitor to have an efficient, safe ovarian stimulation, or can we depend only on ultrasound? Actually, there is here there is for the monitoring of stimulation in assisted reproduction, IVF and ICSI. This is a review, but if you look here, you will find that those are the clinical pregnancy rate, the number of the oocyte retrieved, and the cycle cancellation, and the OHSS rate, mild, moderate, and severe cases. Those in cases where you are using the monitoring here with ultrasound plus estradiol assessment or just ultrasound assessment only. You will find that there is a little difference between the clinical pregnancy rate if you are adding to the ultrasound the estradiol compared with the ultrasound alone. If you go for the number of oocytes it retrieved, also there is an insignificant difference between the two modalities of assessment. And also if you go for the cancellation rate and the ovarian hyperstimulation rate, you will find that there is no significant difference between the two categories of ultrasound plus hormonal assessment versus the ultrasound only. So the recommendation is the addition of estradiol measurement to ultrasound monitoring is probably not recommended. You cannot confirm, you cannot say no, it is of no value, because you have very special situations in which you need to do you have to do estradiol, especially in the high responder patients and especially in the very low or very poor responder patients. Because, for example, if you have a poor responder patient and you are doing the ultrasound and everything is going fine, you have 2 or 3 or 4 follicles going and increasing in size, but you don't have any idea about estradiol level. You can pass the accurate point or the suitable point to end this stimulation. For example, if you do estradiol level at day 8, for example, and you will find it maybe 400, then you need to do it, for example, on day 9. If you will find that this 400 becomes 410, 420, or maybe 390, here, this plateau of estradiol, it has a very important meaning, which means that the granulosa cells are completely exhausted and no more value of prolonging your stimulation, even if the size of the follicles is less than what you need. So this one of the examples that you have to do the ultrasound in combination with the estradiol level. So the addition of the estradiol measurement to ultrasound monitoring is probably not recommended. Okay. Second point is the ultrasound control without hormonal determination for ovulation induction in vitro fertilization embryo transfer with the gonadotropin releasing hormone analog and the human menopausal gonadotropin. Here also we are talking about the ultrasound combination combined with the hormones in an RCT. They found that, they reported there is no difference in the OHSS rate and the pregnancy rate, number of oocytes retrieved, when monitoring was performed with ultrasound with or without hormonal measurement. Okay, here these are the hyper-responder patient. Hyper-responder patient, actually, estradiol gives you no more or no significant information regarding the course of treatment, the monitoring of stimulation, when you can end your medications and the trigger for ovulation. Monitoring of stimulated cycles during in vitro fertilization treatment with ultrasound only. Here also this related to ultrasound in combination with the hormonal profile. This is an RCT reported also. There is no difference in the clinical pregnancy or the number of oocytes retrieved with ultrasound or hormonal panel monitoring compared with monitoring with the ultrasound only. Also related to the number of OHSS, but here also we can see that you have high pregnancy rate, you have high number of oocytes from 10 to 11 oocytes, and we are talking about OHSS. So here we are talking about normal responders or hyper responders. Actually, estradiol is not that significant in these cases. Okay. So addition of hormonal panels
Emad, can you check the, yes, okay. Internet. Emad, the voice is not so clear. We lost voice. There is a problem in the voice, please.
Hello? Ashraf, do you hear me?
Yes, now we can hear you. Yes, now we can hear you.
Okay.
That's okay. Okay, please, the last slide again, please.
Okay. So here we are talking about ultrasound alone or ultrasound combined with the hormone estradiol, progesterone, and E2 during monitoring of ovulation or medication in ICSI and IVF cycle. And there is an RCT reporting that there is no difference in the clinical pregnancy rate, number of oocytes retrieved, and OHSS between the two groups, whether you are using the hormonal profile or you are not using. But actually here you can see that doing an ultrasound plus these hormones, estradiol, progesterone, and LH measurement is probably not recommended. But if we are going or we are planning for fresh embryo transfer, I think progesterone is a very good guide for us to whether to do fresh embryo transfer or not to do it, because all of us know if you have a progesterone more than 1.2 on the day of the peak estradiol or on the day of the HCG, it's preferred not to do fresh embryo transfer, because actually you will have an advanced endometrium and this may decrease your pregnancy rate. It's preferred to go for cryo embryo transfer. So this is probably not recommended, but actually it is not an absolutely no recommendation for that. Second point is that, or second question, does monitoring of the endometrial thickness affect the efficacy and the safety of the ICSI cycle? A meta-analysis combining 22 prospective, retrospective studies and several more recent studies found that endometrial thickness having little or no discriminatory capacity for clinical pregnancy, but this means that measuring the endometrium on the day of embryo transfer, but actually it's very important to measure the endometrial thickness throughout the monitor of the cycle and to measure the endometrial thickness on the day of HCG, the last day of urostimulation, because with the fresh embryo transfer, it's preferred you have an endometrium more than 8 millimeter. With the frozen embryo transfer, it's preferred to have an endometrium more than 7 millimeter. But to measure the endometrial thickness on the day of the embryo transfer, I think it's of no value. Here, the same endometrial thickness on the day of embryo transfer is a poor predictor of the IVF outcome. Actually, we know that in some of those patients, you may find that you have a good endometrium on day 8 or day 9, for example, 10 millimeter. And on the day of the HCG, you may have a thinner endometrium, but still above 8 millimeter. And on the day of the embryo transfer, you may have a thinner endometrium, but actually it is of no value to measure the endometrium on the day of the embryo transfer, but it's important to measure the endometrial thickness on the day of triggering of ovulation. So the independent contribution of the endometrial thickness to live birth likelihood is small and may result in undetermined confounding, but actually remember that here we are telling about the endometrial thickness on the day of embryo transfer. It is of no value, but the endometrial thickness on the day of the HCG is important. The role of the 3D dimensional power Doppler ultrasound parameter measuring on the day of the HCG in the prediction of the pregnancy in the in vitro fertilization cycle. In a large prospective study, no difference in the endometrial thickness between, in contrast, large prospective study reported no difference in the endometrial thickness between pregnant and non-pregnant patients. Actually, this is 9.5 and this 11 millimeter, both of them are okay. 9.5 millimeter, 11 millimeter are okay, but none of them is below the 7 or 6 millimeters. So actually here you are measuring the endometrium, and so long as you have a good endometrium above the 7 millimeter, it makes no difference. Routine monitoring of the endometrial thickness during ovarian stimulation is probably not recommended. The guideline group suggests performing a single measurement of the endometrium during ultrasound assessment on the day of triggering of or oocyte pickup to counsel the patient on potential of lower pregnancy. This means that measuring the endometrium routinely is not recommended, but actually all of us routinely do a routine measurement of the endometrium throughout the stimulation because it's quite easy, and for us just to make sure and safe and to be satisfied that the endometrium has nothing abnormal or nothing that can prevent the pregnancy, or actually all of us measure the endometrium on the day of the HCG. Question 3, if the outcome of the ovarian stimulation depends on the criteria of triggering, if the outcome of ovarian stimulation, how many follicles, the quality of the follicles, the number of mature follicles, does it depend on the criteria of triggering? Timing of the HCG, hormonal administration in IVF cycle using the agonist or antagonist. This is systemic and meta-analysis review. The meta-analysis, including 7 RCTs, investigated the effect of postponing final oocyte maturation by 24-48 hours. If you want to delay the triggering for 1 or 2 days, does it make a difference? Actually, they found that there is no significant difference regarding the ongoing pregnancy rate per oocyte pickup, and there is no significant difference regarding the live birth rate. But there may be a significant difference that when you delay the HCG triggering, you may have more oocytes than early HCG triggering. But the final outcome, or the most important outcome, which is the live birth rate and the ongoing pregnancy rate, it makes some difference. This means that if you oblige or facing a special situation that you have to postpone the HCG for 1 or 2 days, I think it doesn't make any harm for the oocytes or for the final outcome, which is the ongoing pregnancy and and the take-home baby. Timing of oocyte collection in the GnRH agonist down-regulated cycle. This is a randomized controlled study, but the take-home message from this study is that you will find that if you delay your HCG till you reach the 22 millimeter follicle, comparing with the early HCG when you have an 18 millimeter follicle, actually the you will see that the total failed fertilization, it's not that significant. This 4, this 7, I know that here it is quite clear that may be a significant difference, but actually this is a very small number to talk about. This one case that there is no oocytes, maybe an empty follicle syndrome, but this is only one case of an empty follicle syndrome. If you do an early retrieval, here you may face the problem of empty follicle syndrome, but here actually none of those cases had this problem. So the association of the follicle size as the triggering criterion with the outcome has not been sufficiently studied. Physician may choose the follicle size upon which final oocyte maturation is triggered as case by case. I mean, you can manipulate your case according to your experience, according to the situation you are in. The decision of timing of triggering in relation to the follicle size multifactorial, taking account the size of the growing cohort, the hormonal data. Here again, this is the EFRE group. Do we have any problem?
Dr. Emad, please. Sorry. Continue, okay. Okay.
Here, according to EFRE group, first they said that hormonal profile is not important, but actually here they stated that hormonal profile is important, taking account the size of the follicle, the hormonal data on the day of the pursued trigger, duration of stimulation, and patient burden, this is important, and financial outcome. The group of the EFRE does not recommend to base timing of final oocyte maturation trigger on estradiol level alone, but actually you have to do it on estradiol level, progesterone level, and the ultrasound monitoring. And ultrasound monitoring is very important. The last question in this topic, which is which criteria for cycle cancellation are meaningful for predicting poor or high oocyte yield? When to do cycle cancellation in poor responders and the patients with a high response. The poor responder, the EFRE defined poor responder as cycle cancellation or retrieval of fewer than 4 follicles. This is the Poseidon stratification, as Dr. Ashraf said. They defined the 4 groups of the poor responders. You just heard it right now. The first group 1, group 2 are the unexpected poor responders, and 3 and 4 are the expected poor responders. The poor response IVF, if the prognosis always poor, this is a systematic review. Poor responders are not a homogeneous group of women with regards to pregnancy prospects. Female age, number of oocytes retrieved is particularly will modulate the chance of pregnancy in current subsequent cycle. Applying this criteria, the age and the number of the oocytes will allow identification of couples with a reasonable prognosis and balanced decision making on the management of the poor responders. A poor response to ovarian stimulation alone is not a reason to cancel the cycle. All of us know that we may have patients with 1 or 2 follicles that can get pregnant from just only one oocyte retrieve, 1 follicle, 1 oocyte retrieve, but you have to do a very good counseling for the patient before starting stimulation. So very important in the poor responders that counseling the individual poor responder regarding the pregnancy prospects and decide individually whether to continue or to cancel your stimulation. You have to balance also in the high responder patient between the efficacy of your protocol and the safety of the protocol. This regards the high responder patient. We know that the higher the number of follicles you will have the higher the live birth rate. up to the level of almost 20 follicles, 20 oocytes retrieved. After that, you will have no more increase in the live birth rate. I don't want to. So in the GnRH agonist cycle with an ovarian response more than 18 follicles, there is an increased risk of OHSS, and preventive measures are recommended, which include cycle cancellation. Actually, in order not to go for this cycle cancellation, it's better, as Dr. Ashraf said a few minutes ago, that the high responder patient, in order to avoid OHSS, we shouldn't go for the agonist protocol. We have to go for the antagonist protocol, even if you are if you have a big number of follicles, if you have a very high E2, actually you can modulate your protocol and you can trigger your cycle with the GnRH agonist, and here you will reduce or minimize the incidence of the OHSS in order not to go for ovarian cancellation. Reported pregnancy rate among poor responders ranges from 0 up to 18%. So you may have a poor responder patient and she can get pregnant, but you have to do proper counseling for those patients. Regarding the high responder patient, there is no solid criteria to cancel the cycle. A high responder identify women most at risk of OHSS. Therefore, preventive measures are recommended, which could include cycle cancellation. Actually, this shouldn't be the solution. Cycle cancellation shouldn't be the solution for high responder. The solution for high responder is to avoid the GnRH agonist protocol and to go for the antagonist protocol with triggering with the GnRH agonist. This is the first presentation. I know that I have another one about the which more practical and easier about the oocyte retrieval. Can you see the slides?
Yeah, yes, we can see the slides.
Okay. This is easier. All of us know about what do we mean by oocyte pickup or oocyte retrieval. It's an ultrasound guided technique where we aspirate the ultrasound using a needle guided by ultrasound. This needle is connected to a suction pump. We have a lot of basic principles. The most important that you have to be oriented to the ultrasound. The probe should be put in the top or the bottom at the top or at the bottom of the monitor, depending on the operator preference. Some people likes to have the image from up down of the screen, and other like to have it from below upward. I think most of the people here in Egypt, they work for the ultrasound with the picture from down, not from upside down. Avoid contaminating the needle tip of the probe when introducing the vagina. You introduce the probe in the vagina. Don't try to introduce the needle tip after introducing the probe down deep in the vagina. You have to keep the needle inside the needle guide until you reach the uppermost part of the vagina. The ovaries should be lined up to the most accessible position of the on the screen. The transducer should be against the ovary. This is very important. You have to push. Very important, tricky point to have easy oocyte aspiration. You have to push the transducer very firm in the vault of the vagina. Don't put the transducer in a loose manner in the upper part of the vagina. Put the transducer, push the transducer upward, very firm, make it very firm, very close, push it as much as you can, very close to the vaginal wall. Here you can push the needle through the vaginal wall, because the vaginal wall at this situation be stretched, and the needle will pass very easily when the vaginal wall is stretched. If you are away from the vaginal wall, it's very difficult to pass the needle or to penetrate with the needle. This is very, very tricky, and this is very important to push the transducer as much as you can upward in the vagina. Here you can see this is the needle, and these are the follicles. And here you have the picture from the upper part of the screen. This actually opposite to what we do here in Egypt. We do it in the reverse manner. We have this area down in the screen. Most of us do like that. Idea, the needle should be inserted in the middle of the ovary. You have to go in the middle of the ovary. Why? To avoid, to prevent the free mobility of the ovary. Here the needle works as the splint for the ovary, and this is very important to avoid injury of the adjacent structure. Very important also is to see the tip, the echogenic tip of the needle should be identified during all the maneuver. The needle guide should be seen on the monitor, can facilitate safer insertion of the needle. It is advised to keep the needle in the center of the follicle. This is also very important. Keep the needle as much as you can. Sometimes it will be very difficult to keep the needle in the middle of the follicle, especially in the difficult aspiration. But so long as it is easy, keep the tip of the needle in the middle of the follicle and aspirate and observe the follicle wall to collapse around it. The needle tip marker should be observed all the time and maneuvered within the ovary in each follicle. The needle tip should never be advanced if it is not visible. If you cannot see the needle tip, don't advance the needle tip. This is very serious. This is very serious. I stress on this. This is very serious. If you don't see it, pull the needle outside the screen and introduce it once more. This will be safer for you. Okay, aspirate the follicular fluid containing the oocyte cumulus by application of suction. The wall of the follicle will collapse as the fluid is aspirated. Okay, the operator should ensure that all the follicular fluid is aspirated. Another important point during oocyte aspiration: don't do multiple punctures of the vagina. Don't do multiple punctures of the ovary. Don't do multiple punctures of the vagina, because after oocyte retrieval, we have a lot of bleeding from the vagina. Don't do multiple punctures of the ovarian surface to avoid intra-abdominal bleeding. Some of those patients, if you have multiple punctures of the ovary, you may have a significant amount of blood inside the peritoneal cavity, which some of those patients may become hypotensive or hypovolemic. Avoid lateral movement of the needle to reduce the risk of vascular injury. Do not move the transducer with the needle in the advanced position. This is very important, very important. If you want to scan the ovary, if you want to move from one place to another place, and you find that you will move for a big distance, you have to withdraw the needle outside, do whatever you want to do, then introduce the needle again. This is very important. Don't do a jerky movement with the transducer with the needle is present. Puncture all follicles, especially if there is a high risk of ovarian hypertension. If you have a high risk of ovarian hypertension, you have to aspirate the big follicles, the medium-sized follicles. This is very important to take most of the granulose cells out. Flush the needle between the two ovaries to avoid any potential blockage. Actually, this is not that important, but one very important and the tricky point to avoid the blockage of the needle is almost always keep in the collecting tubes just only clear fluid. If you have a transitional pause between aspiration, maybe a few seconds, you will move from one area to another. You are checking whether this is a follicle or this is the vessel. You are facing some difficulty in aspiration. Be sure before stopping aspiration of the oocytes or of the follicles that you have clear fluid in the needle and the clear fluid in the connecting tubes. If you have blood in the needle, if you have blood in the connecting tubes, and you waited for maybe 10 to 20 seconds, you will face a very big problem, which is the blockage of the needle. So very important, tricky point, that you have to keep clear fluid in the needle, clear fluid in the collecting tubal system if you have a delay in oocyte aspiration. Decide the ovarian stimulation protocol, ultrasound prior to oocyte pickup. Before oocyte pickup, very important, you have to decide the ovarian stimulation protocol, determine whether there is any anatomical abnormality or malposition of the ovary, assess the ovarian placement and the ovarian accessibility. Very important point, especially in the busy practice centers, that the person who is going to give the trigger of the HCG should be the same person who will aspirate the oocytes of this patient. I mean, today I'm doing the ultrasound for the final triggering of with the HCG or decapeptyl or whatever. Okay, I should do assessment of the ovarian placement, ovarian follicular accessibility, presence of previous surgery, presence of pathological ovarian cysts, chocolate cysts, dermoid cysts, or whatever. You have to have a map for yourself on the day of the HCG. And this map should be put in mind or drawn in the patient sheet, and you should revise all these data before going for oocyte aspiration. This is very, very important to do all this. If you have any anatomical abnormality or malposition of the ovaries and the uterus, you have to report this and you have to write this down in the sheet of the patient, and you have to aspirate these cases by yourself when if you did the HCG triggering by yourself. Vaginal infection, this is not that important because most of our patients give them prophylactic antibiotics, prophylactic vaginal local antibiotics. Patient medical history, we have to take a thorough medical history for these patients, especially those patients taking the blood thinning agents, either injections or oral medications for that. As OBU is performed under sedation or anesthesia, a full blood count and any additional tests could be done. Here, I think in Egypt, we are doing the OBU, or oocyte retrieval, under general anesthesia. I know that there are some countries doing it under sedation because anesthesia is quite expensive for them. What are the instruments that you need? Very simple instruments you need for oocyte aspiration. This is the cascus speculum, this is the valcellum, and this is a tooth forceps, and this is a gauze, piece of gauze, and this is the aspiration needle. This is a bowel for this infection, and this goes, and this is the needle guide, whatever needle guide you are using. You have to have a high resolution transvaginal ultrasound machine. This is very important. This is the Kraft suction machine, and it's also important for oocyte aspiration to have these portable incubators. These portable incubators are very important for you. You have to have one very close to your IVF lab, and you have to have the other one with you in the operating room, and you have to collect 2 or 3 tubes, put them in this portable incubator, go to the lab and put them in the portable incubator in the lab and return back. From this portable incubator, you will transfer these tubes to this block thermometer, thermostat at the laminar flow. The OBU preparation, it's important that the OBU is performed according to the precise timing. Most of us do oocyte aspiration around 36 hours from the time of the HCG, but it's permissible from 34 up to 38, but actually 36 hours, this is the safest. This is the safety of us, because some of those patients, if you go for 38, you may have some of the oocytes are immature. If you go for 38 hours, some of those patients may be already ovulated, and you will find no follicles at all are present. Immediately before OBU, patient should be specifically asked about timing of the HCG. This is very important. You should have a nursing staff that they have to confirm with the patient that actually she received whatever type of the triggering, or whether it's HCG or GnRH agonist. When the patient took this medication, it's very important to do that, and it's very important to do it in the ward before coming to you for OBU, because you don't have in the OBU to ask this question for the patient. What do we need to give instructions for the patient? That we have to tell the patient should be fasting from food 6 hours, from clear fluid for 2 hours. She must empty her bladder to avoid the catheterization in the operation room. You have to put the patient in a comfortable position for the patient and for the operator, in a semi-sitting position or semi-lysotomy position with the buttocks outside the table. This is very important for free manipulation of the patient. The pivot movement of the transvaginal transducer is easier when the patient places her buttocks at the edge of the gynecological couch and the operating is standing or sitting in between her abducted legs. The surgical theater should be of a reasonable size. It's very important to make the room in semi-darkness situation. This allows better visualization. The ultrasound field and the anatomical orientation are set from the top or set from the bottom as you like. Representation of the transducer from the lower part of the motor may be helpful, as most of us do it in Egypt. This is the way that we are used here in Egypt. We put the transducer from lower part of the screen. I know when I was in the States, we used to do it in the from the upper part of the screen. Anyhow, it depends on what you accustomed to. Before starting the surgical procedure, the pelvis should be systematically scanned to assess the anatomy. This is very important to scan the whole pelvis. Scan the whole pelvis to ensure that the bladder is empty. Scan the whole pelvis to ensure that you don't have any malformations, because you can accidentally discover an AV malformations. You can accidentally discover abnormal vasculature running maybe very close to the ovary or below the ovary, which if you cannot define this, it will be very, very serious and very dangerous complication you may face. If you have chocolate cysts or dermoid cysts, this is very important. So scanning of the pelvis systematically is utmost importance before starting oocyte aspiration. Okay, a large view field is preferable during the OBU. Means that at least 75% of the ovary should be seen. In case of doubt, you can use the Doppler study. You can use the Doppler study. This is the technique for oocyte aspiration. As I mentioned, you have to press the probe firmly in the upper part of the vagina, very, very firm, for easy penetration of the needle. Here, Another point that I want to mention, if you can see here that this is the transducer and this is the needle. Actually, this picture is not quite right. This is very dangerous. You have to have the needle to the back. You have to have the needle close to the posterior vaginal wall, not to the anterior vaginal wall, because here you have a plexus of veins that you may have a hematoma here. So it's better to move the needle guide posteriorly to have okay, I don't want to. This is the follicular flushing, but I think none of us do this follicular flushing. It is not of that importance. And post-procedure care, it's very important that the patient should remain in the ward for 2 hours. In case of significant pain or abdominal distension, blood analysis and ultrasound should be done to check for intraperitoneal hemorrhage. The patient should be able to eat and drink before leaving the ward. And if we have a hematoma or bleeding or infection, we have to go for antibiotic coverage or we need surgical intervention. Okay. Thank you for your attention.